Bruce, did you want something?
I can do it after, Mr. Chair.
Okay. Well, yeah, first I want to welcome to here, and I also want to welcome, there's a group here today. They're on Eagle's Wings. You want to wave over there? They're visiting our committee today. And where are you from? Minneapolis. You've had a long ride to get here, but it's good you can be here, and welcome. It's nice to have you here. And we're going to have actually some interesting testimony today. So some committee meetings are really interesting, and some aren't quite. So this is going to be an interesting one, I think. So I want to have your little, your leadership training, and well, good for you. We need good leaders. So thanks for being here as part of this. And we're going to have a bunch of testimony today and some discussions on 3 different programs that are implemented. Because there's so many people who wanted to testify, I asked if you would put in written testimony, so those are in your folders. First, we're going to hear from the department on all 3 topics, and then we'll take testimony. And I don't know if all the testifiers are, sit down there, Alex. I don't know if all the testifiers are here, but there's enough time to have about 2 minutes apiece. And you'll be surprised how much you can say in 2 minutes if you kind of organize your thoughts. You'll also be amazed how quickly 2 minutes goes by. And that way you get kind of and so as you think what you're going to say, if the person before you said the same thing, you could think of another way to say it that would be helpful. And then you'll actually make your 2 minutes really valuable. So we have a quorum. You actually come to a meeting that's in order. And should we do the minutes? And there's minutes. Who wants to represent Schumacher? Really got a kick out of this batch. Any questions you want to say you want to move the minutes?
I'd like to move the minutes, Mr.
Thank
Chair.
you so much. That's leadership. People behind you have rubbed off on you. Any questions about it? Discussion? Seeing none, all in favor say aye. Aye. The minutes are adopted. Oh, I forgot the no, but anyway. So Ms. Bartolik, welcome to the committee. We have 3 topics to hear about. Are you doing all 3?
I am.
Okay, we're going to hear about PCAs, corporate foster care, and congregate low living needs. And so you have some time. And so maybe if you want to pause after each topic, if there's a member question or 2 about that. And then the plan for today, members and audience, is that we're going to hear department testimony about how they've done this implementation of the last year's bill. And then we're going to have some brief discussion about the specifics. We'll then have testifiers on 4 different topics in kind of clusters, which will be just testimony. And at the end, we're going to get together and talk about a bit more as a sort of a panel-like thing about the corporate foster care and congregate living low needs. So it should be quite a busy day, and I think a lot of good content. So without further ado, welcome to the committee.
Thank you very much, Mr. Chair and members. I'm Alex Bartolik. I'm with the Department of Human Services, and I will be giving you an overview of how we have implemented the 3 provisions, and we'll pause after each one for you to ask questions. One of the first provisions was a cost-saving measure to reduce the reimbursement to PCA providers by 20% when a relative provides the PCA services. And a relative in this situation is defined as related through blood or marriage in one of the following ways: as a parent, a sibling, an adult child, a grandparent, or a grandchild. The law required implementation on October 1st, and we worked with some of the home care providers to understand how best to document when PCA did provide services to a relative, and we implemented on October 1st. On October 26th, there was a temporary restraining order. We are paying for PCA services at the full PCA rate, and we are continuing to collect information on those claims that are made on behalf of PCAs who are relatives. In the event that the court upholds the PCA relative caregiver payment rates, DHS may collect the overpayment from providers. Because of that condition, there are some providers we know have established escrow accounts and are putting the difference between the 80% and the full amount in escrow so that they have it available if they need to reimburse the department or to be able to pay the PCAs the full rate that's coming forward. At the beginning of this month, what we have found is that there are 29% of personal care assistants provide services to relatives, And on the flip side of that, about 33% of PCA recipients receive at least some of their personal care services from a relative. And I pause here and see if you have any questions.
Is that all that's your testimony on the PCA thing?
It is.
Yeah. Is the judge, whenever they get around a ruling, you said people are escrowing money? Is
Not
one of
all. We just have heard that some providers, because the department is able, it doesn't say a decision has been made, but at the event of a lawsuit, if the reduction is upheld, the department could recover the overpayment from providers.
Oh.
And so some providers have chosen to establish an escrow account so that the money's available to repay it or to provide the full reimbursement to their employees.
And could the judge then make a decision that it would be only carried forward from here, or that it could be retroactive? Is that a decision that they can make?
I'm not in a good position to answer that.
Oh, okay. All right. And I don't want to, if you have to just not answer some question because of the litigation. That's just a curiosity question. Representative Liebling, maybe you know the answer to my question.
Thank you, Mr. Chair. And Ms. Bartalik, I apologize if you answered this and I missed it, but could you just tell us how much do PCAs earn and how much are the relative PCAs now earning after the reduction, just to give us a sense of, what are we talking about here?
We don't have the exact data on what the wage is. In 2009, there was a provision that at least 72.5% of the rate should go to wages and benefits for PCAs. And I'm just blanking. I think it's about $16 for a unit of PCA services. Can somebody? I know there's people in the audience who have that. I can get you the exact dollar amount of what the rate is.
Representative Liebling.
Thank you, Mr. Chair. I hope someone will give us the dollar amount during this hearing, because I understood it's something in the range of 9-something an hour, and that's before the cut. I might be wrong about that, and I know it might vary, but I think it's really important for us to know.
We can get you information on what we understand to be the range of the wages that are paid by agencies. So even though we don't have all the specifics, we do have some information from a survey from providers, so we can let you know the payment rate and what the range is. We also know for PCA Choice, which is a program where people can select the person they want to do their services, and they handle more of the training and the monitoring of the services, that in those situations, people have tended to make a little bit more money, but we'll get you that information.
Okay.
Representative Liebling, I think that it's, that they're required to, the agency is required to spend 72 cents on a dollar on wages, and they can retain 28% for administrative or less, up to their choice. So I think it's in the range of 11 something or other. So,
Yeah.
Representative Liebling.
Okay, thanks, Mr. Chair, and maybe somebody will, can clear that up. But also, I was wondering if you could just sort of, real briefly, give us a sense of what these people are doing for the money, because I think I've heard from a lot of constituents about this issue, and as you probably know, I have a bill in to restore this cut, and the stories I've heard are really pretty heart-wrenching, and they're people that are working as a personal care attendant for a relative, and they probably are working a lot harder than they would be if it was for somebody they weren't related to, because this person's welfare is really important to them. They've often given up other jobs to do this and are not only able to afford to do that because of the help they get through, the wages they get through the PCA program. And so I wonder if you could just kind of give us a real quick sense of sort of the range of duties that these people are performing.
Maybe a short list, Ms. Bartoli, and we can,
Real
just
high
a
level.
flavor.
Often, individuals who may need assistance with bathing, getting dressed, help in the morning. They may need assistance with food preparation. It could be more of a continuous or around specific tasks. Often PCAs also will be there to provide support. So if there is something that happens, they can assist the person, do some redirection or assistance if something is occurring. So it is a pretty wide range. PCA is a state plan option that's available to people who have a functional need, and it's primarily looking at whether or not they need assistance because activities of daily living, or things such as bathing or eating or toileting or dressing, those activities transferring, or because of intervention due to behaviors. So there can be a wide range of activities, and it's a service that really has helped many people stay at home and avoided the use of other services. And Minnesota is a state that has allowed relatives to provide care to individuals, and in some cases, as you said, people are there, they're already providing quite a bit of care, and if they are able to be paid for it, they can be there more consistently. We have had people who haven't been able to keep a job because they have had to be there if a PCA didn't show up, and this has brought stability into it.
Okay, thank you.
Interestingly, there'll be a number of witnesses talking about some of that, too. And I just want to point out that I believe Minnesota is one of 21 states that provide some level of relative-based services. 29 do not provide any. And it was a House provision that came from me. So I'll take, if you're mad, don't. She's the implementer of what we helped them to do. And the challenge wasn't, and the point wasn't to be unkind to a loving family member, but to keep the system intact. And the choice was that or another 0.8% rate cut for the entire continuing care system. That was the choice, and we had to find about $1 billion at the end. We left this committee with $1.863 billion, which was a really scary number, and came back with about $900 million, about half that much, in various ways. And the point of today's hearing is to look at some of the things that were in that mix, and what can we do to ameliorate some of the issues. The program was set up not as an income stream for families, so that was. And because of the economy, it was the only remaining job for some of these families. I didn't know that at the time. And that was quite a surprise from the 100 letters or so I got. But it was designed to be a way to focus on the client to have access to services. If you remember what we said all along, is it about the client, or about the vendor? And that's a little disrespectful when it comes to a relative, but still the client is the person tried to protect at the end of all this. And the vendors have to adapt. And many vendors will tell you that with the rate changes, they've had to do some changes they didn't really like. And it's been quite a hard process, but I just want to tell you that for your enlightenment. And we'll be discussing this more, I'm sure. So I think we'll move to thank you for that.
Mr. Chairman, before we...
Oh, Representative Kiffmeyer. Sorry,
Thank you.
I forgot.
That's okay. And Ms. Bartolic, while you're getting information, if we can just add the average number of hours on a weekly basis to that information about the range of pay, if that would be okay?
Yes, we can do that.
Thank you.
I can tell you 25 is real common for these families.
Okay.
But you'll get real data. So the next topic is corporate foster care implementation.
All right.
Is that what you want to do?
I can do that one.
Okay.
One of the provisions was around corporate foster care and having reduction in capacity when somebody leaves. I believe that's the one you're talking about. In 2009, the legislature established a moratorium on the use of corporate foster care. And corporate foster care are settings where the license holder does not reside in the residence. It's often by a provider who provides staffing to support the people who are there. And we have seen a lot of growth in corporate foster care, and it's a service that has worked very well for many, many people. However, facing choices of limiting waiver growth even further or finding less costly ways of supporting some people, a moratorium was put in place hoping to work within the system to better allow people with higher needs to access that service and to support others in other settings. This summer, there was a provision that required the immediate reduction in the capacity in a corporate foster care setting when a person who was living there chose to move out into a community living setting. So it's not all times somebody moves. There's many reasons people move. But if somebody during an assessment says they would like to live in a setting that's their own apartment, where they hold the lease, where they decide who's going to come in and assist them, and they're not going to live in a licensed setting any longer, when they would move into that setting, that bed would close. At the time, it was estimated that 128 people over the next 2 years would move out of corporate foster care settings under those conditions. It was a modest savings. It was $1.3 million over the biennium. We have not yet implemented this. Between the shutdown and a number of provisions that needed implementation, we had to prioritize our efforts. We also recognize as we get ready to implement, we will need to work with stakeholders to be able to come up with the best ways of managing this. Some of what we've come to understand and that we think is a common agreement with many people is we need a better planning process to really understand where the needs of people are, what the capacity is across the state, and how to better match capacity with needs. And that would be something for a future direction to look at how to better manage some of this.
Questions from members? Representative Huntley?
Yeah, I just want a brief answer. It says here spouses cannot be individual PCA providers. Is that correct? Because I've had spouses complain about the 20% cut.
That's correct, and maybe we could follow up with some of the specific situations.
Okay. I know that we're on a different topic, but but there is, I'm not sure if all the committee got that letter or that memo from you about the national approach to this family PCA thing. That would probably be productive to see just how diverse it is across the country. And it's almost undescribable without reading it. It's so another federal document.
We could make sure.
Yeah,
that
Representative Murphy, did you have a question?
Thank you, Mr. Chair. And, I just wanted to underscore my agreement on the last point that you made about planning. And I as we have been through, now what seems like 5 years' worth of cutting in Health and Human Services, I feel like we are not at all focused on the future for the state. I mean, we are individually, but we're not doing work right now that's focusing on a future where we have an aging population. We have so much work to do, and I don't see how this committee by itself or the one in the Senate can do that planning, but we have to do it in conjunction with the administration and with stakeholders in Minnesota. So I put that near the top of the list, or maybe I should talk with the commissioner about that, but it's so critically important, and it's in the wake of all that we've been through, it's being left behind.
I agree. I have a couple comments, but are there any questions people have from members? Okay. Just to that point, and we're doing pretty good for time. I think this is a bottleneck in this system in terms of planning. I've spent, you get kind of ratcheted way up when you have to sit in this chair. Right? A lot of meetings like, holy cow. But I've come to realize that the department has a feeling that there's too many corporate foster beds. But they don't know how many you need, but there's too many. That's like the nursing home bed question. And so this was an effort. This was a bit of a surprise, the way it all turned out in the bill to me. And I admit I'm responsible for this, but I didn't think of this one. And I'm glad the department has taken the time implementing this. It saves a little bit of money and can cause some disruption. There are some very large corporate foster providers for whom one bed is nothing. And some, if you have a very small agency, it's like they're ruined. And so we're trying to find a way to balance out this bill with its merits. But there's a piece that at the end we're going to discuss some of the future possibilities. That last panel is a bit of a foresightful thing, so hopefully we can do some work there. So I'll stop there. Ms. Bartolik, you want to take the third topic, please?
Yes, for the third topic, it relates to rate reduction for certain individuals who have been determined to have lower needs who are living in certain congregate settings, and this was estimated to save $12.7 million over the biennium. The language is specific to people who are on the CADI waiver, which is the Community Alternatives for Disabled Individuals, and the Developmental Disability waivers. And the congregate settings refer to corporate foster care settings for both people on CADI and DD, and then customized living for people on CADI. And in this, I just want to point out, one, that any reduction has a big effect on providers and individuals, and this was one of a number, and it's been difficult to implement for all as we've gone forward because we understand that this has been an additional reduction. Also, the term lower needs is a really relative term. People already have been certified as disabled, They have met criteria saying that they are at risk of living in a nursing home or an intermediate care facility for people with developmental disabilities if it weren't for these community services. And for many of these programs, we have waiting lists, so they've also been identified as rising to the top in terms of priority. So this term relative, lower need is relative to people on the program. It really does not in any way mean to indicate people do not have significant needs. The criteria for the reduction was looking at basically the needs for hands-on assistance with these activities of daily living, which are things we do to take care of ourselves and to eat and get dressed and transfer and be able to have movement around. And no, or relatively lower, again, relatively lower interventions due to behaviors. We also, after working with lead agencies and a number of stakeholders, added additional criteria. People were excluded from consideration for this if they had entered into the waiver program within the previous 24 months from either an intermediate care facility for people with developmental disabilities, or a nursing facility, or a correctional facility. And then further, we also excluded people if they had entered onto the waiver in the previous 24 months, within 24 months, and they had received an identified mental health service within 90 days of coming onto the waiver, or have used those services within the previous 12 months. So there were some efforts to look at indicators of whether or not somebody is stable or not. And then through that, there was a 10% reduction. It's a provider rate reduction onto those particular services of customized living or the corporate foster care. In the end, there were 756 people on CADI whose services had a 10% reduction, and 890 people on the developmental disabilities waiver. A couple of comments about this. We know that the screening documents that are used are not sensitive to some of the complexities and different needs of people that are using the services. And that in part is why we did design a new assessment process, and the legislature authorized that in 2009. We've developed the instrument. We have done an initial testing, and now we are in the process of developing and testing the software, the training, and then doing some more testing to see if it's working as we intend to. And what we're trying to do is do a better job of really assessing people's needs, their strengths, the circumstances around that, to get at some of the subtleties around eligibility and more particularly service planning that we don't currently have in our system. We know that the 10% reduction in and of itself is a provider reduction, and it's not appealable. What we have asked providers and counties to do is to work together. Some providers have been able to accommodate the reduction. Others, and not that it's easy to do, I don't mean to suggest that, but they've been able to maintain pretty much the same level of services through mechanisms such as perhaps reducing staffing but using technology or making other arrangements. But for others, it's been difficult. And service plans, we know, may need to be amended. And if a service plan is amended and it's a reduction of service, the person can receive a notice of action, which is one trigger for appeal. But if for some reason the service plan isn't amended or there isn't a notice of action, if individuals still feel that they've had a reduction and a disruption in their services, they can appeal. But what isn't appealable is the fact they were on the list. But if they can explain how this has affected them, that can be heard. There's been a question that's been raised quite a bit about whether or not the rate reduction had a disproportionate effect on individuals with mental illness. We know particularly with the CADI program over the last decade, there's been a lot of growth in the use of these services for people, particularly as the mental health system's gone through a lot of restructuring. So to begin with, we have a lot of people who have a mental health diagnosis who access the CADI service. We don't have a good indicator, but we do have a way of saying there is one data element that says that a person has a history of a mental health diagnosis. Doesn't mean that they currently are receiving services for a mental illness or how recently it was, but it is an indicator. And we know that there are a high percentage of people on the CADI waiver who have had an indicator of a history of a mental health diagnosis. Now, the percentage of people who live in corporate foster care or customized living with that indicator that they have a history of a mental illness diagnosis is the same as the percentage of people affected by the cut. So it's proportional to the number of people, the same percentage. But we do know that a lot of people with mental illness access it, and that has had an effect. I will put
Thanks.
it up for-
Questions for Ms. Bartolek? And so this is a challenge. We'll hear some of the witnesses talking about it, and we'll be maybe covering this a bit in our panel. But this is something that I've spent some time on, and I'm open to advice from members and the public about how to properly target these reductions. And now, if the provider decided that the person could warrant a service reduction, they could make that decision, and then the person could appeal that. But the provider could suggest a service reduction, given this reduction in money?
Providers, because their rate is reduced, they will have to figure out how to manage their business within the rate that will be given to them. And if they think that, sometimes, again, they might be able to make it so it doesn't dramatically affect services, but if they feel that it's going to really significantly impact what they're able to do, they should work with the county to see if the service plan needs to be amended. And that, if to the recipient it's a change in service, they can appeal that.
Right. I mean, if everybody's agreeable, they could reduce services and the person could continue on. But so they're not barred from reducing services, but that makes it an appealable circumstance.
Mr. Chair, is your question if a provider felt they could reduce services outside of this reduction, but if they just were serving somebody and thought, you know what, we could do this for less money, can they do that?
No, I'm just
Okay.
I'm not sure what I'm trying to say, really. But well, just that the providers are, this 10% of these people does not give the provider the right to reduce services on its face.
Correct.
But they might look a little closer and say, well, we could do without this one. What do you think, Mary? If, oh, yeah, I could go without that. That would be fine. And they could accommodate that way if they had an agreement and if it wasn't appealed, right?
Correct.
Okay.
There may be ways that a service plan where people would be okay with that.
Okay. Well, very good. It gets pretty complicated, but it's really important. And so we're going to hear some of the, I think you're done for the time being. So we're going to move into our testimony time. And so we're going to go down the list, and these are kind of clustered by topics. And so Tom Johnson and Lee Lewis would come down. And then on deck will be John Everett and Craig DeLorme. And if you can stick to around 2 minutes, that'd be nice. Andy's going to hold up a sign at 30 seconds. And we're not going to have you stop your sentence at that time, but just kind of understand. And we discussed the more focused you can be, the better. And sometimes 2 minutes is like just a ridiculously short amount of time, in which case you have to come talk to us privately, and we'll do the 20-minute chat, this may foster a lot of those. I know the members in the committee are very interested in this on both sides of the aisle. So.
Thank you.
Oh, yeah, and by the way, we're on TV today, so you can say hi to your mom or whoever. But so be sure to speak into the microphone so that it'll carry over the meeting. So I presume, Mr. Johnson, welcome to the committee.
Thank you, Mr. Chair, members of the committee. My name is Tom Johnson. I'm a client advocate with the Mental Health Association of Minnesota. I'm also a parent of a son who has a diagnosis of schizophrenia and has done very, very well in spite of having that diagnosis. I have myopic degeneration, so if when you get close to my time, would you wave it instead of just holding it, because I don't see very well. You're all pretty blurry to me. I could have talked about any of the topics here today, but I'm really I'm going to spend my 2 minutes on the low needs assessment. It's a real concern to people with mental health issues. Ann Henry provided some testimony in a written format to you, and I read that before I came over here today. It stated basically that the assessment form is in great need of revamping and better addressing some of these issues that we know that people with mental illness deal with. A few years ago, when I first started dealing with my son with mental illness, many people in our state, I don't know the number exactly at that time, were in hospitals or regional treatment centers. Over the years, Minnesota and other states have done very well in getting people out of the regional treatment centers and the high-cost, high-intensity service and into the communities. And one of the reasons they've been able to do that was because we had some community services available. Not always as much as we wanted, but they were sometimes available. And if you worked hard, you could find a way to get them. We did with my son. And he got out of the hospital, but I'm very concerned. I deal with people, many people with mental illnesses need some kind of a low, they don't always need high levels of care in their home, but they need a little bit of connection once in a while to make sure that they're able to, they're not confused in their medications, and they're taking them as prescribed, and that they can get help with groceries, or that they don't lose their housing because they're not maintaining it. I certainly deal with people all the time who are struggling to maintain housing, and they need someone there to structure. Thank you. I'm sorry. I went over.
That was very helpful. Doesn't it go quick?
It does go fast.
So, thanks. You can just step aside, Mr. Johnson. Thanks for coming, and thanks for your firsthand thoughts there. And Mr. Everett, John Everett is on. Oh, are you John Everett? Okay. Oh. No, I mean, Les Lee is going to go, and then John Everett is.
Is Lee next? Or?
Lee Lewis is next, and then. And then there's do y'all have the sheet here?
All right.
So anyway, so hi. And then John Everett's on deck, and then Craig DeLorme, Alan Potvin, Joe Cuoco, and Lisa Zastel. So anyway, welcome. Sit down, sir. You can have
Well, I have.
We have a whole crew. Oh, never mind. We'll stand then. Okay.
We'll stand.
Go ahead.
All set?
Sure.
Mr. Chair, members of the committee, my name is Lee Lewis, and I'm the Executive Director of Clare Housing, the largest provider of supportive housing to people living with HIV and AIDS in the state. We operate adult foster care, permanent supportive housing, and 24-hour customized living services. We house approximately 150 people in these settings. 50 of these individuals live in one of our 6 adult foster homes or receive customized living services through the CADDY program. 60% of those were subject to the 10% low needs cut. I suspect that so many of the people who live in our housing were subject to that cut is because over 80% have some level of cognitive impairment due to AIDS-related dementia, traumatic brain injury, mental illness, or chemical dependency, and the tool that was used to determine low need did not adequately capture the need for behavioral interventions. The cut was unexpected and, quite frankly, unsustainable. It was also shocking because over the last 6 years, we have consistently and tenaciously innovated new programs and services to reduce costs and support people in independent living situations. We've utilized the new license in foster care that allows for overnight supervision using electronic technology to save over $50,000 per year in 2 homes. And we have utilized asleep overnight care instead of asleep awake care in 2 homes for a savings of $50,000 per year for those 2 homes. Our most innovative change, however, has been to layer 24-hour customized living onto permanent supportive housing to meet the needs of a substantial segment of the folks in our adult foster care homes. In fact, when we opened Clare Midtown a year ago, 5 of the 45 units in that building were taken by individuals who had been living in adult foster care. We were able to serve them at about half the cost of the state's CADDY program, and they live more independently in their own apartment to which they hold the lease. Furthermore, in some cases, instead of GRH, a state program providing the rental assistance, a federal program, Housing Opportunities for People with AIDS, takes care of the housing component. So we work incredibly hard to find new solutions to serving the poor, ill folks in our community, and this cut felt more like a slap on the hand than a pat on the back for good work and partnership. So I hope the legislature considers rolling back this 10% low need cut.
Thank you. We've had good discussions, so thanks for coming. Mr. Everett, you've got
I got a crew.
a crew there, and
We'll be quick.
2. Oh. We didn't know you were bringing all your friends, but go ahead. It's nice they're all here.
Thank you. Mr. Chairman, members of the committee, I'm John Everett. I'm the Executive Director of Community Involvement Programs. We run a number of adult foster care homes, both for people who are developmentally disabled and for people who live with mental illness. I don't want to say too much other than I think we want to take a little bit of issue with the appeal process. A lot of people who are designated low needs tried to appeal that label. They were summarily denied a hearing. Most of them couldn't do that. The people I brought with me today, actually, I'm handing out a letter from Ted's parents. Ted is a resident of one of our adult foster care homes in Minneapolis. 2 of those 4 individuals were on the low needs list. They both appealed. They both were summarily denied any hearing at all. And so I wanted you to meet Ted. He came out of Anoka 8 years ago and has been living in the community and living the life that we all want to enjoy. So I wanted you to meet Derek Allen, who was our house manager, who manages that house in Minneapolis, and Ted Link, who lives there. So I'm going to turn it over to them.
So if you want to take a minute each to offer a thought, that would be really nice. When you and say your name, please, for the
My
record.
name is Derek Allen. Ted, would you like to go first?
No thanks.
Okay. My name is Derek Allen, and I'm the house manager at the home where Ted lives. And I would, follow up what John said, that it seemed as if we had 2 of our individuals, one of which was Ted, who got the rate cut, and it didn't seem as if that was really evaluated, because while the guys are doing very well at the home, it seems as if they were looked at the times when they were getting the services provided and are very stable, and it's not considered that that's not always the baseline.
Thank you. Ted, do you want to say something?
We obviously think too much about ourselves and listen a lot to a little piece. We like to seize and develop, but the thing is, overseas, our hearts don't evaluate. It's kind of an evaluation of how we listened and didn't keep our socks in a loose place.
Yeah. Ted's very nervous. This is very intimidating. So,
Ted, you did great. Could you say your name just so that we can remember your whole name, please?
Theodore Link.
Thank you.
If I may add, Ted
Please, if
worked
you would.
on, when his rate was cut, he worked on a paper for 2 weeks for his appeal before it was denied, so that it wasn't even considered. And, I think he deserves to be heard.
Well, thank you.
If you have a lot in the last place where you look for your laundry, then definitely understand a corner is best for the socks.
Well, thank you, Ted. I appreciate that. And Mr. Everett, thanks for bringing your group. I appreciate that. And next we have Craig DeLorme and Alan Potvin's on deck.
Mr. Chair and members of the
Yeah,
committee.
please sit down.
I'm not Chuck DeLorme. I'm
Oh.
going to introduce Chuck.
Oh, talk in the microphone.
Great. There's
Okay.
Craig, and I'm going to introduce him. I'm Tim Burkett, the CEO of People Incorporated. You have a packet about us.
Hey, Tim, talk in the microphone.
Oh, yeah.
Break the microphone.
You have a...
By the microphone.
I'm Tim Burkett, CEO of People Incorporated. We have programs throughout the metropolitan area for more than 600 people with mental illness in more than 40 locations. And our programs and our clients, most of whom are very high needs, were hit big time by the 10% caddy cuts. And I'm not here to talk about that in particular today, except to say that more than 50% of our clients were hit by them, and that this has caused distress for many of our clients. I'm introducing Craig here, Craig DeLorme, who's going to talk about his experience in our program for people with epilepsy and mental illness. 9 out of the 14 clients in this one-of-a-kind program in the state were determined as having low needs by the assessment tool and got the caddy cuts. We'll simply have to close the program if the cuts are not restored. So Craig is now going to speak to you, and he's accompanied by his staff member, Anne-Marie Florist. Thanks.
Hello, Craig. So take a minute or two, and I know that's a short amount of time, but it's nice to have you here. So tell us your name and then what's on your mind.
Hello, my name is Craig Dorm, and I'm a current client with People Incorporated Epilepsy and Mental Health Services. And I've been with the program since August of 1998, and I was got a notice saying that I was like low need, and yes, I can do like dress myself and shower fine, but there are some days when all the clients in the epilepsy program might have like what I would like to refer to as seizure days, and if they have seizure days, then their judgment can become cloudy and they might not think as clearly. And if this program were to close, then I would probably have to move to like a group home and relearn the bus route all over again with new staff. I'm pretty sure that the other clients, if in this program at this time, if the program were to close, they would have to move to different group homes as well, and then relearn the bus system all over again, and to like where they need to go.
All right. Well.
Granted, they could also, if they were approved for Metro Mobility, they could give Metro Mobility a call as well. And
If you could kind of wrap it up, it's helpful to hear what you have to say, but you're...
Say, Craig, Anne-Marie would like to say something.
Well, Mr. Burkett?
Go ahead.
Mr. Burkett, you're 5 minutes into a 2-minute slot.
Okay, she's just going to
Just so you know.
I think just the severity of the hits we took with the 9 out of 14 with epilepsy, it's clear that it didn't necessarily assess that accurately or well, maybe, because seizures are very unpredictable and the effect of the seizures is really unpredictable. All of our clients need 24-hour access to staffing. Group homes would be a much more expensive alternative for those folks.
And we need your whole name, please.
Anne-Marie Florist.
Thanks. And Mr. DeLorme, are you on the caddy waiver?
Yes, I am.
Okay. And this is I've talked a lot about these kinds of situations. I'm glad the committee can see them firsthand. So this is helpful. So thank you very much, and thank you, Mr. DeLorme, for coming to visit us today, and the rest of you. Mr. Potvin and Mr. Cuoco, I believe, are on deck. Alan, are you here?
Thank you, Mr. Chairman.
And just, Alan, you and Joe at least are going to be later in the meeting, too, and so we're going to be in a little panel, including the two of you, so just so you can help focus your comments. Okay, good. Go ahead, Alan.
Mr. Chairman, members of the committee, my name is Alan Potvin. I'm from northwestern Minnesota, 50 miles west of Bemidji. My wife and I own 4 assisted living facilities and provide elderly waiver services to the majority of our residents. In the last 3 years, elderly waiver has received 4 cuts. These cuts are close to being unsustainable. No, that's not the word. I'm sorry. I cannot maintain this. I have elderly waiver clients. In one facility, it's 70.07%. In one facility, it's 92.8%. In one facility, it's 67.61%. Altogether, they add up to a percentage of elderly of 76.52%. Facilities that accept elderly waiver clients also get hit another way as well through the GRH program, the rental assistance program. We have in various facilities, we're losing from the normal rent $24,000 in one facility, $44,000 in another facility, with it, and $14,000 in another facility, for a total of $101,000 a month in what we should be receiving for rental income. A formula needs to be devised for the facilities that accept elderly waiver clients, and especially the ones that accept elderly waiver clients in high numbers. There are assisted living facilities, 24-hour customized living facilities, that do not accept any private pay or any elderly waiver clients. Some facilities will accept just a few percentage. Up in northwestern Minnesota, where I am located, in the 3 of the poorest counties in the state of Minnesota, it's not unusual to have 70, 80, 90, even 100% elderly waiver clients. We're taking a tremendous hit, where other facilities, other assisted livings are not getting this hit.
Yeah, thank you.
Thank you.
Yeah, thanks. And so you'll come back later at the end of the time, so you can go take your chair. And then if Lisa Zaspel wants to come, and hello, Mr. Cuoco, welcome to the committee.
Hi. Thank you, Mr. Chairman and members. My name is Joe Cuoco. I am the Vice President of Supportive Living Solutions. We provide services to 120 severe and persistent mentally ill people that live in our customized 24-hour customized living apartments. I will try to make this really quick, since a lot of this stuff has already been covered. I just want to mention about 76% of our clients also have been taking a hit, so it just kind of makes me question about the disproportionate number of people on the mentally ill side being hit. But also, I just want to talk about the assessment tool. I mean, it's admittedly flawed, but it seems like we have to, I know there's something in the works, but in the meantime, we have to deal with it. And it really hurts the residents, the clients, and that's what this whole thing's about. It's not about the businesses. Yes, we're getting hit, but it's about the clients that we serve. So until there's a better assessment, they just have to deal with it. The appeals process has been flawed because they're saying that it's not a direct hit on them because it's the finances go to the companies. And so when we appeal, pretty much right away they say, well, you can't appeal this. The rule against us, the rule against the clients, because they don't have a real voice in it because the money is going towards the company. It's kind of a backdoor approach of cutting services. So I just want all of you to take that in consideration when dealing with this subject, that through layoffs, closures of facilities, in the end, it really does hurt the people that we're trying to provide and provide services for. So thank you so much.
Well, and thank you for coming. Now, that's part of why we're having the discussion at the end. You represent one of the services that actually is in the community and trying to do what we're trying to do. So, and just to help the audience, we were oversubscribed on people who wanted to speak. We tried to accommodate everybody. We asked a few to take a defer since they're here all the time. But that's why I'm being so short, not to be, actually be more respectful than less respectful. So, like Mr. Coco spent a half hour in my office, so I got to hear a longer version, Mr. Potvin and others. And so I invite them to go visit other members as well and help them understand, because we got to find some of the answers. And go ahead, you can ditch, and then maybe Miss Zespel wants to come. And I hope people are recognizing this as a way to try to be collaborative in solving the challenges we face. I don't remember sitting in many meetings in my other 12 years where they would look back and see what happened after we did a bill. So, anyway, that's just, so we're kind of a team here, I hope. Anyway, welcome to the committee. And
thank you. Chair Abler and members of the committee, thank you for the opportunity to speak with you today. My name is Lisa Zaspel, and I work with Fraser. We're a nonprofit provider of health care, education, and housing services to thousands of children and adults with special needs. I'm responsible for the management of 26 four-person foster care homes. Each day I see how these services keep people with significant disabilities as independent and engaged in the community as possible. I will focus my comments today on the 10% low needs reduction that was targeted to individual resident clients. A total of 8 residents at Fraser received the 10% cut. In our experience, the affected clients do not have lower needs. As an example, one of the women affected has a significant physical needs, uses a wheelchair, and requires a high level of staffing to provide physical transfers and other cares. I recently met with another one of the affected residents and his family. His mother asked me to share this quote. She said, "There's no other setting that could fully meet John's health and safety needs. Not only would it be unreasonable to force him to move into a less supported environment, but taking this choice away almost certainly would lead to regression of the challenging behaviors that he works on every day to overcome. He truly would lose his independence without these services." We have implemented a number of measures in order to continue serving our clients. For example, we used to take each client to their preferred place of worship on the weekends. Now we can only afford to take all residents in a home, as a group, to the same worship destination, regardless of their preference. I'd like to conclude by underscoring 2 points. First, we support the effort to create more robust assessment tools to help ensure that the clients can get the services that they need. Second, we are concerned that the residential system might not be able to withstand any more uncoordinated reductions. We are particularly nervous about the potential disruption of the up-and-coming waiver rate-setting methodology, as well as the threat of the additional 1.67% contingency rate reduction. Before additional changes are made, it will be important for us to set long-term statewide goals for disability housing, and then take coordinated actions to achieve these goals. Thank you again for the opportunity to share with you today.
And thank you. And I've had some good meetings with the Fraser folks, and
Thank you.
you're part of the solution, so thank you for that.
Thank
Okay, we're going to keep going through our list. They're kind of clustered to help out, so if Dr. Hulbert would come down and Linda Massica. There's 4 people in this next group, kind of about corporate foster homes. And then, are you Dr. Hulbert?
Yes.
Okay, and then
Good
Linda
afternoon.
Massica would go sit down next to her. Is she here? Anyway. And then Cheryl Grassi and Kyle Mullen are on deck. So welcome to the committee. I'm sorry for the short time you get, but please make the most of it.
Yes, thank you for the opportunity to speak. My name is Alice Hulbert. I'm a retired anesthesiologist, and I've been on the City Council of Edina, and I also own a house that is a group home. My son is 26 years old, and he's pretty significantly impaired, and he moved into this house in June. The moratorium needs to be lifted to bring new vitality and competition into the system. The moratorium affected our family in these ways. When it was time for Trevor to move into the community setting, the only house that would accept him was in Elk River, and we live in Edina. He is very significantly autistic and needs the support of his family and community behind him. So our only option, we followed the path that a friend of mine, Peggy Krolick, who's here today, had taken and bought a house and started a group home on my own. And our house has 3 people living there now, and we've contracted with a company to provide care for the young men who live there. The effect of the moratorium has dampened competition and locked everybody into one space, which they're not able to move out of. There's geographic maldistribution of the resource beds, and there's become a proliferation of unlicensed sources, of unlicensed settings like mine. Some are good and some are questionable. I think my representative, Keith Downey, is introducing a bill, House File 2061, that would repeal the moratorium, among other things. If that bill passes, it doesn't mean that everyone has to license their home, and it doesn't mean that the only licensed site would be 4-bedroom group homes. I think there's a lot of innovation out there in alternative settings, but I do think you need licensing in these different sites. And I offer the Bloomington codes for rental property as an example of a way to get some licensing to assure health and safety and good use of taxpayer dollars, but not have to recreate the wheel. We have our house licensed as rental property, and it far exceeds what the DHS needs for group home licensing. Thank you.
Thank you very much. Is Ms. Masica not here? Is that you?
Yes.
Okay, people can come and sit next to each other. That will help the
okay.
flow. And otherwise, the waste 30. Hang on a second. So if Cheryl Grassi wants to sit next to her, and then Kyle can move into the chair when Ms. Masica leaves. Thank you. Welcome to the
Representative
committee.
Abler, Chair, and Representatives, thank you for being here. My name is Linda Masica. I am a former Edina 8-year council member. I have been the chairman of the board of the Animal Humane Society. I have been on the board of directors of Metro Cities and on the Finance and Tax Committee of Minnesota League of Cities. I want to get into a little bit of personal things that show you how I am personally impacted by what is happening in this committee. For years, my husband and I looked forward to the birth of our first grandchild. In fact, I told my husband, either these kids reproduce or you get me a lapdog. Fortunately, I got both. My oldest son had a set of twin boys. These were perfect babies. They were so gorgeous, and it was so much fun to hold them. Unfortunately, as they started to develop, in my mother's heart and in my gut, I realized that there was something wrong with the babies. And as they turned out, one has Asperger's and one is autistic. I'm going to deal with today with some of the things that Dr. Hulbert said, so I'm going to go through them very quickly. And that is, we need an end to this moratorium. We need to have options. We need to be able to have the kind of care that provides for the future of Max and all the people like him. We need to be able to withstand various kinds of opportunities, or to stand for various opportunities, because there is an explosion in autism. Autism has just, particularly in Minnesota and California, has absolutely run wild. We don't know why, but it is increasing the number of people that need homes, they need good care, they need quality service, they need the kinds of homes that we would all like to live in. So I'd like to say thank you to Representative Keith Downey for championing our most vulnerable citizens and coming forward with House File 2061, and I'm asking you to please ensure my grandson Max's future. Thank you.
Thank you for your testimony. And so then if Mr. Mullen would join us, and then welcome to the committee. On a related topic, I know. Go ahead. Ms. Grassi, please.
I'm Cheryl Grassi, and I am here as a parent, but I am also a professional in the autism community. I'm the parent of a 13-year-old boy with severe autism who currently lives in a group home in Chisholm, Minnesota. He lives in Chisholm, Minnesota, 4 hours away because there are no openings in Hennepin County for children with autism or any other developmental disability due to the moratorium. Prior to his living in Chisholm, Seth lived in a for-profit group home in Brooklyn Park, Minnesota, that repeatedly had licensing violations and complaints to Child Protective Services. This company refused to provide any programming for the children's disabilities and kept my son primarily institutionalized in a room watching videos, day after day after day. They felt that their responsibility did not extend beyond basic care, which is all that's required by the county. And with the moratorium in place, the beds, the slots in the group homes are so valuable and there are so many people waiting for them that providers really have a monopoly that allows them to reduce quality of care. So we see a pervasive reduction in quality of care. Now, this is not every provider. There are very good providers out there, but there is a pervasive reduction in what kind of care has to be given when you can kick someone out. Anyway, the moratorium has taken away my right as a parent to advocate for my child's needs. When I asked for autism programming or better quality of food in the group home, ramen and water was a common meal in this group home. I was told that if I didn't like their services, I could go elsewhere, but of course there is no elsewhere. So essentially we searched for months and finally found an opening on the Iron Range, which is where he's living now. I would just quickly reiterate that the autism community is really greatly impacted by the moratorium. We're the #1 state in the country for cases of autism, and there are a large, large number of children about to enter the system that will need housing over the next few years, and something has to be proactively approached about the lack of beds. Thank you.
Thank you for your testimony. Mr. Mullen, and if Brooke Schultz wants to step down next to him, that'd be great. Mr. Mullen, welcome to the committee. Tell us your name.
Chairman. Thank you, Chairman, Committee, for the opportunity to speak today. My name is Kyle Mullen. I am a senior leader with a group home and in-home service provider in Rochester, Minnesota, Cardinal, Minnesota Limited. And first off, I want to say to Mrs. Grassi, that's a horrifying situation for your son. And I am proud to say I come from a provider and know of a few others that would be very horrified to hear of such a situation. Because unlike other companies, a lot of us don't gauge our success by storing clients or warehousing them and keeping them for long periods of time. We gauge our success by helping them become more independent, by increasing their quality of life. When we have someone who's able to move into a more independent setting, we consider that a big reason to pat ourselves on the back. And that's when we come into the problems with the 10% cut. You've already heard a number of times over people's concerns with the phrase low needs, so I don't need to dive into that. I would suggest instead that the better concept for those same individuals is highest potential. At a town hall in Rochester, I was surprised to find that there was a misconception that these individuals were receiving the same amount of services at the same cost to the state as somebody that had significant medical needs or did not fit the criteria. And that was actually not the case. We were already providing the minimum services to help them be independent and successful at a reduced cost to the state. So when those minimum services to help these individuals were cut by 10%, that made a very big impact on their ability to be successful. And when we were also faced with the moratorium, it's caused, one of the unintended consequences was that counties have become competitive for spaces. We've got, and a number of other providers have beds that are open, but our counties don't want those to get filled just in case a more needy person comes along. That makes a significant impact on our ability to operate as is. The 1.5% across the board cut, combined with the 10% cut, we were not hit as hard as other people. It came to a little over 3% across the board. Combine that with the cut in 2009, we're operating at 6% less funding than we were back in 2009. Like I said, our focus isn't on funding, but in the face of things like that, we find it very difficult to help people become more independent and move them into innovative settings. Another part of the competitive part of the moratorium is counties are very afraid of allowing us to offer different services. Variances applied for being turned down. So we find ourselves tripped over at a couple different points there.
Thanks. Doesn't 2 minutes and 45 seconds go long? Go quick? So thank you. I'll let you go. I just wanted to hear your point, and it's productive. And just so people know, the moratorium was not part of this bill. That was 4 or 5 years ago, or I don't remember what year, but that just so you know what we're talking about today. And we had those the cluster of people talking about that just to get a bigger planning picture and so on. Anyway, so Ms. Schultz, welcome to the committee.
Thank you. My name is Brooke Schultz, and thank you for allowing me to testify today. I'm testifying on behalf of recipients and providers of CADI-funded corporate adult foster care, as many of our former folks here have done today. I'm the Associate Director of Clinical Services for South Metro Human Services. We're a nonprofit agency. We provide a number of different types of services. With foster care, we provide services to 60 people with serious and persistent mental illness living in our corporate foster homes. Our folks have access to staff 24 hours a day, and the concept when we initiated it was that it would be a permanent living situation. I'd like to discuss the implementation of the low needs cut and, of course, also of the decertification. Regarding the low needs cut, as many folks mentioned, there was no definition of low needs for many months. At first, we received one list of low needs folks, then we received another list. We've had some difficulties with determining whether or not those lists are accurate based on some of the testimony that was heard earlier. In any case, when the screening tool around this was eventually unveiled, it appeared as though it was much more weighted toward physical needs. Folks with mental illness have difficulties in service needs that are complicated by their mental health diagnoses, and the concern, of course, is that this tool has disproportionately affected them. Implementing this cut has been incredibly difficult. Some of our homes have reduced staffing where we can. That leaves me as an administrator with grave concern for safety of everybody, staff and clients alike. Sometimes our homes are staffed with only one person to serve 4 people, so a 10% cut, how do you cut that 10% of one person? Not applicable, not useful. I've talked about thinking about decreasing training for staff. That's not a good thing. When we're working with folks that have clinical needs, and we'd like to provide training and clinical ability for staff working with them. Recreational outings are something I've also thought about chopping. Not excited about that either for a number of different reasons. Our folks need community integration. With regards to decertification, the idea there would be that decreasing licensing by one person for a 4-person home would decrease our ability to provide services by 1/4, making it impossible to continue operating a facility at 75% of the revenue. I know my time is up, and yes, it does go fast. Thank you.
Thank you for coming, and it does help to hear all the different voices. So, Ms. Abderholden, welcome, and then if Mr. Webb would have a chair. Welcome.
Yes, Mr. Chairman, members of the committee, my name is Sue Abderholden. I'm Executive Director of NAMI. The law that closes a bed once someone moves out will negatively impact people with mental illnesses, since if a program provides intensive services, there's a good chance they will recover and move out to a less restrictive setting. So now those foster care homes that do a good job will be penalized. The criteria simply that someone moves out does not help us distinguish between those homes that provide quality care, that have staff that are trained in working with people with serious mental illnesses and are supervised by mental health professionals, from the ones where police have been called, people have been tased, or people have wandered off and died in the river. There are waivers for people with developmental disabilities, brain injuries, the elderly, and then there is the CADI waiver developed for people with physical disabilities. There is no mental illness waiver. So what you have is a square peg like this trying to fit into a round hole, the CADI waiver, because that's all there is. Anytime you tighten up the nursing facility level or a CADI waiver criteria, people with mental illnesses are disproportionately impacted. Let's take feeding. If you can't bring the spoon to your mouth, you obviously need help. Well, what if someone is delusional, and so while he can bring the spoon to his mouth, he won't leave the house to buy groceries because of his paranoia, can't cook due to his disorganized thoughts, and time is surreal, so he doesn't even know he hasn't eaten for days. Under CADI, this person would most likely be low needs, but mind you, neither of these individuals will eat without help. The assessment tool used to determine low needs is deeply flawed and looks at behaviors, not symptoms, does not take into account what is needed to stay stable in the community, looks at daily, not weekly assistance, and uses words like cueing and redirection, words that are not used in the mental health system, and also they do not adequately look at suicide risk or ideation. The CADI program doesn't recognize the cyclical nature of mental illnesses, or that while a small percentage of people need intensive services for most of their lives, most people need intensive services off and on throughout their lives. So as the square peg, we are tossed out, and it's unfair and unjust that we need to stop disregarding the needs of people with mental illnesses. Thank you.
Sounds like you're advocating for a mental health waiver.
I certainly am.
Thank you. Mr. Webb, and then if Mr. Nelson would come down. Thank you.
Mr. Chairman and members of the committee, my name is Jerry Webb.
I have a son with a serious mental illness, schizophrenia, residing at Minnesota Security Hospital in St. Peter. He's been there for over 8 years, and during this time his symptoms have been reduced, and he's doing a lot better. At the beginning of December, we were notified by staff that he'd be moving into from transition care to adult corporate foster home. He was accepted and for placement. I was very overjoyed. I want my son closer to home and have an opportunity to begin his life in the community. I was not happy when I was told there were no openings in any of the corporate homes at this time. They have no openings, and nor they can open a new home to meet his needs. Now, after 2 months, he's still waiting for an opening. I understand there are 17 or 18 others like my son waiting to move out in the community, but they can't because there are not enough corporate foster care homes. I would assume a foster care home would cost the state a lot less than continued stay at the state hospital in St. Peter. That's probably the most important point. NAMI and I understand just need to slow down the proliferation of corporate homes, but instead of stopping all development, I would urge you to look at the needs are and what to provide for quality services and develop a proposal that takes all of these items into consideration. NAMI and I know that all too well they're serious enough not to accept housing options for people who can live with a serious mental illness. Corporate foster care, good quality care, provides a less restrictive setting for people leaving the hospitals and leaving residential treatment and institutions. And that is, as the first individual said, this is what I think you've tried to develop a few years ago, is to bring people out in the community and out from the institutions.
Mr. Webb, your time is pretty gone, so I think you made a good point, and thank you very much. And then if maybe Ms. Simons would come down. Hello. Hello, Mr. Nelson.
Hello, Mr. Chair. My name is John Nelson. I'm the Executive Director of Residential Services of Northeast Minnesota. We support people with all disabilities and operate several foster care homes. I did provide some written testimony, so I'm not going to repeat that here. I'm going to just try to highlight a few things, if I may, to make a few key points. One was just to reiterate what Ms. Aberholden said about the delicensing bill is going to end up closing the very providers you need, because they're the ones doing a good job moving people into the community, and to close those beds and then end up causing the harm to the provider and to the 3 clients remaining. Earlier you said that larger providers might be able to handle that loss. Remember, when one person leaves and that bed closes, there's 3 people left behind that are very impacted by that. In terms of the 10% cut, I'm not going to repeat the same problems that were experienced that you've heard about already. What I want to talk briefly about is that we actually have a home that had 3 out of the 4 clients identified as low needs. And I would tell you they're probably correctly identified as low needs. So here the assessment maybe worked, okay? But no, there's nowhere for them to go. There's nowhere to wait. There's no way to reduce services. In St. Louis County, if you wanted to reduce services, it would just result in a larger rate cut. So there's no reduction of services, but in this particular setting, you couldn't reduce them anyway. And what you need to do is look at why are they still there, and to answer these questions about the moratorium and finding more beds. The beds could be there if you could look at what's keeping people in foster care. The fact that the CADI waiver has restrictions on the number of people in the settings. The fact that shelter needy, the funding that could help them afford housing, has too many restrictions. The fact that the affordable and accessible housing in the right locations where transportation won't be an issue has to be addressed. And you have to look at the inequity between the waiver and the service menu, because some of the waivers have such inflexibility that you can't create the types of services you need to support yourself in the community. All of these things are going to, or could be addressed in Representative Schumacher's bill that he'll be presenting to this committee, and we appreciate his support of that and hope you will also support it. Thank you.
Thank you, Mr. Nelson. If Dina Belisle would come down and sit next to Ms. Simons, welcome to the committee.
Thank you very much, Chair Abler and members of the committee. I'm going to switch gears a bit and talk a bit about the 20% PCA relative wage cut. I see on the agenda that there's a lot of parents following me who can probably speak more intimately to the issue, so I'm actually going to try to stay under a minute with my testimony I did just want to say briefly that, given that I work for a broad disability policy organization, we get contacted quite a bit by individuals and families about various cuts to disability services that are impacting their lives. And in my 4 years with CCD, I have never experienced the volume of phone calls, emails, communications that I received when Minnesotans learned from their PCA provider agencies about this 20% relative wage cut. Just very briefly, the high-level messages that I heard and a lot of the stories shared with me were that a lot of these individuals and families are incredibly hardworking. They didn't turn to PCA services and to providing those services via a relative until they absolutely needed to, until they had ran out of all other options. Many of the mothers providing PCA services left other well-paying jobs to do that. And secondly, I heard a lot of anxiety and fear about what will happen next, because the reality is that these wages are helping pay for the out-of-pocket expenses that families incur when they do care for their loved ones at home, whether that be gas for trips to the doctor's appointments, medication, maintenance on accessible vehicles. So, we're well aware of the difficult budget situation that we face as a state and that we likely will next year as well. But to echo other folks' thoughts, we really believe that without a vision for the future of disability services and a plan process for getting there, cuts such as the 20% relative wage really do little to save our state money in the long run and make life incredibly difficult for the families who are saving us thousands of dollars by caring for their loved ones at home.
Can we please say that under a minute took a minute 40, just so you know. Okay. Could you please say your name?
Under 2.
No, you did good, thanks. Could you please say your name?
Ani Simons.
Thank you very much. Welcome to the committee, and if Barbara Christensen would come down, please. Welcome to the committee, Ms. Belisle.
Hi, my name is Dina Belisle, and I am a single mother of a almost 1-year-old child who's severely disabled. I didn't start being his PCA until he was 22 years old, because I was always able to take care of him. But once he starts missing schools and being absent by like 48 days a year, I was missing that much for work. So I chose not to have a PCA non-family member come into my home because my son is nonverbal, and even though he has taught me how to communicate with him, it's hard for me to teach somebody else that, since it's taken us so long. My salary always, no matter if I was working outside the home or now, has always contributed to his well-being. He has to go to the dentist. We got him down to every 3 months. Now, we don't have the coverage anymore from MA, so that out-of-pocket expense comes out of my pocket. Adapted swings, fencing in the yard for his safety, expanding the bathroom to get him in and out of the shower, all that came from my salary and will continue to do that. It's been stated that, family members are going to continue to take care of them, and that is true and untrue. We physically and emotionally can continue to give them the support, but this 20% cut to our wages gives us 20% less to them, and that's just not fair. We are very sacrificing people. We love our kids. They are our round-the-clock priority. We are there for them 24/7, 365 days a year, and would do anything for them. Thank you.
Thank you, Ms. Belisle. I really appreciate your comments. And then if Bruce Emmel would come down. Welcome to the committee, Ms. Christensen.
I'm Barbara Christensen, and I'm here for a personal reason. My husband, Charles, is a PCA for our son, Stephen. Stephen's 48 years old, and he has progressive MS, and he's had it for 21 years. Stephen gets 10 hours PCA, 4.5 hours waiver. My husband was earning $11.25 and was cut 20% plus 1.5% for being a PCA, which now his wage is $9.05. This is a hardship. Charles is 77. I'm 72. We're retired. For a while after Stephen moved in, I worked as an airport security guard for a few years to supplement our income. Stephen is a 24/7 client. Most nights, myself or my husband get up to meet his needs. If not for us, he would be in a nursing home. I suppose you're wondering why we didn't put Stephen in a nursing home. He was only 33 when he moved in with us. He was married, and after 7 years of MS, his wife divorced him. His sons were 5 and 8 at the time. We'll always remember the call telling us he had bad news. His wife wanted him to leave. How could we put him in a nursing home? We only asked for help the last 8 years, our income being so much less, and the extent of care Stephen needed, it was necessary to ask for help. When we met with Anoka County, it was the hardest thing to ask. We've all paid our ways, never asking for handouts. A little background on Stephen. While in high school, Stephen joined the Silver Bay Volunteer Rescue Squad, being the first student to do so. When he graduated, he went to Lake Superior College to be an architectural draftsman. Stephen paid his way through college working at a nursing home. He worked for Contardo, the city of Duluth, and his last job was for Builders Commonwealth in Duluth as a case manager. He's been a wonderful son. How could we put him in a nursing home? But for the grace of God, this could be any one of your family members. Could you put a son or a daughter in the nursing home at 33? Every night when lights are out, we hear, "Thank you, Dad. Thank you, Mom." The mindset of many people is, sure, they live off the PCA money. We use the money to help with the cost of caring for Stephen. We wouldn't need a 2-bedroom apartment. We tried to move into subsidized handicapped apartment, but 3 incomes were counted. We couldn't qualify. Other places, we found only one parent could live with Stephen. We had an apartment we could move into, but we had to pay their carpenter to make doorways wider. We feel we've saved the state of Minnesota money. We even bought a handicapped minivan for 11 years ago, $37,000. We've taken Stephen to doctor, dentist, and eye appointments. And then his father gets cut 21.5%. No one, unless they're very, very rich, can afford a catastrophic illness. Please, please, don't make life harder for relatives who care for a loved one. Coping with the illness is hard enough. Thank you for hearing our story.
Thank you, Ms. Christensen. If Jamie Knopik would come down, and I let you go 4 minutes just because I appreciated your testimony, but if the other people could try to stick it under 2, that would be helpful. No, I appreciate your testimony. It was very compelling. So hello, sir.
Hello there. Mr. Chair, committee members, my name is Bruce Elmo. I'm the President and CEO of Home and Heart Care. We're a personal care provider located in Clearwater County. We have 223 PCA recipients, and 53% of those are located on the Red Lake Indian Reservation. The rest are spread over a 10,000 square mile area in northwestern Minnesota. Home and Heart Care serves roughly 1% of Minnesota's PCA recipients, but 49% of all our active PCAs live on the Red Lake Reservation. Last fall, we discovered that 57% of all our PCAs met the relative criteria. That's almost twice the 29% average that the DHS has estimated. But there's a more profound statistic that DHS does not track. I can estimate that 99% of all recipients living on the Red Lake Indian Reservation had some type of relationship to their PCA prior to their start of PCA service, whether that relationship was a relative as defined in Minnesota statutes, or a cousin, nephew, significant other, or family friend. I can make this estimate because of the 230 PCA recipients in the 6 years we've provided service. We've only successfully placed 2 PCAs on the Red Lake Reservation that were not previously known to their recipients. And unfortunately for Red Lake recipients, the 20% lower reimbursement rate for relative PCAs only penalizes those closest in blood to the recipient, and in the opinion of our recipients, those most vested in their cares. It has made our job of finding qualified caregivers that much harder and has forced good PCAs to look for jobs elsewhere. I've got three other points, but I emailed them to you so you can read them later. But I just want you to support, if you would, House File 1907 and the repeal of the 80% relative rate cut. The lesser rate is not pro-family, it's not pro-life, and it's discriminatory to minority communities. And additionally, passage of this bill would stop the litigation and remove the fear of the DHS clawback that currently places smaller providers like ourselves, which serve low-income and minority communities, at a financial disadvantage. Thank you.
Thank you, sir. Appreciate your testimony. And if Christy Sanford would join us, welcome to the committee, Ms. Knopek, right?
Thank you for giving me the opportunity to share my story with you all. My name is Jamie Knopek. I live in Ham Lake with my husband and my 3 children, all of whom have high needs and autism, as well as developmental disabilities. Like any parent, we plan for their futures and we hope for the best. Unlike any parent, our children's futures are uncertain and unpredictable. We never know if at any moment one small group of people can make yet another decision that will forever impact their lives. That one small decision to cut their funding, their stability, even their health care. We cry ourselves to sleep at night wondering what will happen to them when the government decides their most vulnerable citizens can do without dental cleanings, certain medications that help them endure life, and even our livelihoods. My oldest son is 10. He's on a CADI waiver. Last year, we had to choose, due to the 10% cut, we had to choose if we wanted to lessen his supervision or go without behavioral services, so we had to get rid of his behavior services. He is a joy to us, but he's very challenging. His behaviors are so severe, he has never been able to have a regular PCA that's been able to deal with his behavior for longer than a month. He's so severe that if we can't care for him at home, he will need to reside in a facility in which the state will have to pay for 24-hour one-on-one supervision. We are hoping to keep him home with us for as long as possible, but with losing nearly $3 an hour in pay, I am now looking at finding another full-time job to compensate for the wage loss. Nearly $3 an hour in pay cut means hamburger helper instead of pot roast. It means tuna instead of tilapia. This leaves us once again looking at placements for my son. Working is not an option, it is a necessity. Being able to earn a living and give good care to our son was a godsend. It alleviated many of our fears, and he was not as much of a burden to the state. Children with the right services can go far, but with greed and lack of services, they will end up in a home cared for by poorly paid strangers, eking out a sad existence. Please help me keep my children home, happy and productive.
Thank you. And if Austin Figge would join us, that's the last of the witness list. Welcome to the committee, Ms. Sanford.
Good afternoon. My name is Chris Sanford. I am a parent of a young man with multiple disabilities. I am also a PCA RN case manager. My son requires medical supervision and 24-hour care. After having been sexually assaulted by a male PCA at age 17, we now have family providing all cares. All PCAs in the program are subjected to law that is identical in expectations, rules, and supervision. The contention that family members do not provide appropriate care based on a few bad cases is unfortunate and untrue. As a professional, I see caring, reliable family members as PCA who have better understanding of the needs of the client. Yet, they are denied wage and benefits of equality. The logic and cost effectiveness by cutting wage to family members providing PCA service is flawed. It represents a stopgap measure to balance the state budget after costly and unnecessary shutdown. It was a decision devoid of long-range planning and input from those who receive or provide service. The PCA program is the most cost-effective program serving our most vulnerable in the least restrictive environment. It offers LRE, community inclusion, and prevents the warehousing of individuals based on disability. The 20% wage cut to family members is excessive, discriminatory, and causes undue hardship. If not appealed, we will see escalating costs to taxpayers to care for individuals placed in long-term care facilities as families are no longer financially able to keep them home. I believe we risk seeing increased desperation on the part of families, which could trend toward increases cases of neglect, fraud, and abuse. My son, having waiver, is now on a different program than PCA to reduce the impact of the cut. As a professional, I have seen a decrease in number of those qualifying for the program and caseload cuts. The program simply cannot weather any more cuts and maintain the quality service it provides. Representative Abler, you are right. I will do it anyway. I will continue to care for my son by any necessary means. It is my right, my duty as a parent and as a human being. I am conservative. I believe in fiscal responsibility. So, I reiterate, the PCA program is the least expensive alternative, and the wage is not excessive compared to costly alternatives. As voters, we hold our elected officials to a high standard and accountability, and I will be basing my vote on those criteria. Our elderly and our veterans have earned their keep. Our disabled have no choice. To abandon responsibility to those with disability is cruel. When we fail to care for our most vulnerable individuals, humanity and civilized society cease to exist. Thank you for your time.
Thank you very much. Mr. Figge, welcome to the committee.
Thank you, Mr. Chairman, and other members of the committee. My name is Austin Figge. I work for Prairie River Home Care in Buffalo, Minnesota. I'm also a Minnesota Home Care Association board member. We've heard a lot of testimony from caregivers themselves. I have many employees like them who I probably could have brought in a dozen to tell the very similar stories themselves. I'm not here to speak to that today. It sounds like we've got that pretty well covered. What I'm here to talk about is the effects of this caregiver cut and how it was implemented and the administrative burdens that is put on the agencies that are trying to comply with them. How this was implemented was they introduced several forms, as usual, that had to be created for pretty much every single PCA caregiver interaction in Minnesota. And so while I thought when this came through it might be, we might need a form for every relative and caregiver, it's implemented where you need a form for every single interaction. So if it has no relative whatsoever, there are stacks and stacks and dozens of forms. It's almost like a paperwork trap. Other things that were affected by are the billing codes and the claims and how that was handled. It was really bad at first. They pulled that back a little bit so that the billing situation isn't so bad. But when you think about the burden of how we implement this, and if you service any of the HMO plans, you pretty much exponentially multiply the administrative burden on agencies to perform these tasks. Now, couple that with reimbursement cuts of other sorts, I would say that the administrative burden that home care agencies deal with now is quite remarkable, related to the fact that we're pretty much operating at 2006 pay rates, and we have many, many times the administrative burden that we normally would. So I guess that's not my time there. My alarm is going off. In conclusion, I guess, I'm not here to, argue whether relative caregivers should or should not be providing services. I think everybody else is doing a wonderful job at that. But as sort of a representative of an agency trying to implement these changes, with the lawsuit and the stop and the implementation of it and things like that, we're just looking for some sort of stability. Personally, I think the administrative burden is overly heavy, especially on this level of care, on a PCA caregiver. It is almost far more challenging to provide PCA services than it is actual skilled nursing services due to the administrative burden that it has with it. So I guess please pick something and stick with it and help us out here a little bit. Thank you.
Well, thank you. And just to you, if there's some specific things that seem unnecessary and burdensome at the administrative level between you and the department, we discuss those things all the time. And, they mean better than it seems sometimes. Some of the things that we have to do are just silly. And so then we take that up and do some bargaining with them to get rid of them, and the federal people are far worse, just so you know.
I'm well aware of that.
Anyway, so thank you for coming. We're going to change gears, but I want to thank the people who testified, and I hope that everybody felt respected to get to say their piece. I've had many discussions like this through the session, and since I thought it was productive for the committee to hear some of these firsthand things. It's hard to hear some of these stories. These are compelling, and it's bad politics to have this kind of a meeting. But I think it's good policy and it's good work. And I think we need to be accountable for who we serve, how we serve them, how to better do it in the future. And if you don't get feedback, we can't do it right. We have only a few minutes left, but if Mr. Potvin and Mr. Coco and Ms. Aspel, Mr. Lewis, Bruce want to come down. I wanted to talk about, I'm going to just narrow the focus of this, but the department is convinced, and I kind of agree, that there are too many corporate foster beds. I think they're spread out wrong in some cases, but there's not an option to where to go after that. And I've had many, many meetings with people, and there is not a very good community option. And so I'd like to talk with these people, just however briefly, about, like Mr. Cuoco has found a way to, in their supportive apartments, where they save $100 a day on people that might be in a corporate place. And so, and that's controversial to some time. Just pull up a chair, Mr. Potvin, in there. And so I was hoping for a little more time about this, but we're intending to work on this a bit. And so the time being what is, I was hoping for some committee interaction, and that's not going to happen, obviously. But maybe just if each person would take a minute and say what you see as barriers to community options, that'll be what we're going to get out of today. So it's kind of an abrupt change. But I think we've all been compelled by the testimony, and so how do we do it better? What's the next step? How do you move? How do you make the money go further that we have? Everybody, just to the testifiers who are concerned about reductions, you look at the federal budget, you look at the state budget, there's no pot of gold coming. The feds are 44% overspent. They need to cut $500 billion or something, to make the budget match. Greece is almost out of business. And so we cannot simply restore what we didn't pay for anymore and think it's going to go on as well. So how do we find a way to do it better and more focused to the clients and respectfully look after the families who take care of their kids and their mothers and all? That's the challenge. So Mr. Coco, do you want to just, we've had longer meetings, but can you just do a minute about where you see a barrier to more places like yours?
Yes, definitely. I think part of the barrier is, part of it's because of understanding federal regulations, what DHS is interpreting, what the federal the direction of the CMS guidelines, and that's creating a barrier because they don't, obviously they don't want to go against the federal regulations, so they're not allowing for growth in the 24-hour customized living field, when it's definitely one of the cheaper ways, affordable ways to service the mentally ill. We provide, just a quick background, we provide apartments to each person. They have their own key, they have their own lease, kitchen, bathroom, bedroom, everything. And it provides as much independence as they can have. Unfortunately, a lot of these people won't be able to move on beyond this because they just fall apart on their own. But right now, there's a stoppage because they're trying to determine what course DHS is trying to determine what course of action to take. What's considered an institution is a 20 to 30 unit apartment considered an institution, where they each have their own unit, or just items like that.
Okay.
What can we do? And so what I discussed with you was the whole process of allowing the people that are in the no more than 4, the ones that would be lower needs might not need the 1 to 4 ratio to move into customized living, and that would create a snowball effect to allow other people to move into the no more than 4 settings as well.
Right. Mr. Nelson, have you thought of a pretty good minute to offer me here? I know you've been listening all day, so. if you can keep it to a minute, that'd help.
Thank you, Mr. Chair. I am Bruce Nelson with AUTM. We're an association of providers who support people with disabilities. And regarding the delicensing and the 10% reduction, we understand the intent, but the way of getting there to finding economies and moving towards more options for people who are overserved in corporate foster care is really putting the cart before the horse. So as Mr. John Nelson mentioned earlier, we do have a bill that Representative Schumacher is authoring. And you mentioned barriers, Mr. Chair, and one of the key barriers is housing and the portability and use of housing. And if we can open that up without, in a budget-neutral way, and our bill does address that, then that eliminates one of the real barriers that we now have in the current system for people to move, because when you move, you have to have a roof over your head.
Okay, thank you. That's, time's up. So you gave your pitch earlier, which wasn't my question, and then you burned up your time. So, and I gave you a minute and a half. So, welcome. The Fraser Group has been very responsive and not very involved in the policy side, helping us stop. They've been reactive, but I really admire you for your work. And I know that, can you just comment about your view of 4 in a place and that?
I think we have a real passion for how we serve our individuals, and 4 in a group home doesn't always mean that that was the magical number that the state came up with many, many years ago. And I think part of the things that tie our hands to do services, if we continue to do them the way we did to reduce cost and overhead, is the amount of duplication in the regulations and the licensing. And I would like to look forward and move forward on how to decrease those, as well as looking at how we determine what risk is and who determines that as a team for an individual. And I think that is a heavy cost to the provider to meet those needs.
Thank you. And Mr. Lewis, you could kind of just, you see the trend we got going here.
3 quick things.
Yeah.
Number 1 is the size and setting issue around congregate settings and this limit of 4 people. That's absolutely critical if assisted living-like services are going to be available to people who are not over 65. That's 1. Secondly, flexibility. I deal with a population that has HIV and AIDS. Not everybody is disabled, but the system is set up for disabled folks. And so be aware that the needs are different for different populations, and build in flexibility to whatever systems you put together. Third one, pay attention to the global waiver, the Medicaid waiver. There's some incredibly important things in there around permanent supportive housing and services in housing. 3 points, less than 60 minutes. 60 seconds.
And Mr. Potvin, without saying what they all said, can you offer a thought on this number thing too?
Well, I'm coming from a different perspective in the fact that we're from the poorest counties in the state of Minnesota, in northwestern Minnesota, and the elderly waiver program has been cut 4 times in 3 years, and the last cut is 5%. Well, there's too many facilities out there that only take private pay. They don't get any cut whatsoever. Other facilities might take just a few % private pay, and the cut they get is absolutely minimal. For us who are averaging...
We already heard you say that. Can you talk about numbers and size more than 4 in a place? And then we're done. So we talked about that in our office, remember we...
Right. Well, I don't deal with the 4 beds, so, I'm not in this discussion as such.
Right, but you were looking for flexibility, and we talked about...
Well, I feel that something needs to be done so that those that do care for the poor population, the elderly waiver people, don't get a considerably larger cut compared to no cut for the facilities that only take the private pay people.
And that's a credible point, too. So
I would, for a suggestion, I would suggest that if anything is done on this, it would, in my opinion, it would almost have to be retroactive in order to be equitable.
Yeah. So we're out of time, but you can see we have our hands full. I hope you can sense, you didn't get to hear the committee talk, but to the witnesses who are still here, we care a lot about everybody who came. We care about the topic. It's on our mind a lot. We're looking for a better way to do it, still understanding the context we're in, which is the whole federal money and the state capacity. And so this discussion will go on. I think this was a productive day. A lot of stuff jammed into one hearing. Thanks to all who participated. We're back on Tuesday. Oh, at the joint hearing, is that valid? Oh, Tuesday is the Valentine's Day joint hearing on the health plans and that. That should be very interesting. That'll be a 3.5-hour deal. You can 5 minutes. But thank you all who participated, and thanks for your good work today. We're adjourned.